What's up, Ninja Nerds? In this video, we're going to be talking about acute ischemic strokes. Before we get started, it's very important for you guys to continue to support us by hitting that like button, commenting down in the comment section, and please subscribe. Also, we're going to have a link right here where you guys should click. We're going to have comprehensive notes, illustrations on acute ischemic stroke that'll aid in your academic understanding of this topic. So let's dive into it. All right, so let's start talking about acute ischemic stroke. Particularly, we have to talk about the causes of it, the etiology, and then how those particular causes lead to acute ischemic stroke, the pathophysiology. What we're going to do is we're going to talk about the causes in different categories, if you will. So I like to break them down into global hypoperfusion, you're not getting enough oxygen or blood flow to the brain. Second one is there's thrombotic causes. There's a clot within a vessel that's actually occluding blood flow. The third one is embolic. There was a clot somewhere, there was in the heart, another blood vessel somewhere that broke off from that location and circulated up and got stuck somewhere in the cerebral vessels. The next are the other causes, which aren't the super common ones, and that includes vasculitis, dissection, and hypercoagulable states. And we'll go through each one of these in great detail. The first one that we have here on the docket is global hypoperfusion. So these are very commonly known to lead to what's called watershed infarcts, and I'll explain what that means a little bit later. So first things first, what are causes for global hypoperfusion? The big things that you guys really want to remember here is when someone has significant, and I mean significant, cardiogenic like shock or failure or cardiac arrest is kind of like the best thing to say. So let's say that we talk about cardiac arrest. When someone goes into cardiac arrest, their heart is not pumping any blood out. Right? If you don't pump blood out of the heart, your cardiac output is pretty much null. You don't perfuse, your mean arterial pressure is going to be low, if it's and actually maybe null, and then that means that you're not going to provide oxygen and blood flow to the cerebrum as well as other organs in that case. If you don't get blood flow to the cerebrum for a prolonged period of time, it can lead to ischemia, if not corrected, infarction. So it's important to remember that cardiac arrest, the whole concept behind this is that there may be a significantly low cardiac output that leads to a significantly low mean arterial pressure. And if you have a very, very low mean arterial pressure, are you going to perfuse the brain as well as their other organs? No. And if that happens over a long period of time, ischemia, infarction can progress. The other thing to think about here is, what if somebody not only had, let's say that they actually have blood flow to the brain, but you don't have any oxygen going to the brain. And so maybe someone is in severe acute respiratory failure and they're not actually ventilating, putting oxygen through their lungs and into the pulmonary capillary blood to come back to the heart and then push blood up to the cerebral circulation. That could be another one. So acute respiratory failure, if you will, and the whole concept behind this is that there is significantly low oxygen. If there's significantly low oxygen, that's going to lead to ischemia. Even if you have regular blood flow, if you don't have a good oxygen carrying capacity from a severe hypoxemic hypoxia, that's going to lead to ischemia, and if not treated, infarction. Okay, another potential cause of global hypoperfusion, besides cardiac arrest and acute respiratory failure, would be something where, let's say someone has a really pretty significant carotid stenosis. So they have a big fatty plaque within their internal carotid artery. So here, let's put ICA stenosis. So they have a really bad critical ICA stenosis, like let's say greater than 70% of it's like clogged with a big fat plaque. And very little blood flow is getting past that. Well, you know your ICAs supply your anterior circulation and supply blood to the brain. Let's say that now you're already getting very little blood because of this bad stenosis. On top of that, you have low blood pressure. So let's add on to that, and you have something where that causes your blood pressure to drop. So you develop low blood pressure. Okay, and what would I mean by this? So for example, this can happen when someone is getting their blood pressure dropped too quickly, too abruptly. Maybe they came in with high blood pressure, you gave them antihypertensives and tanked their pressure so low that they don't have enough pressure to push through those little narrowed stenotic areas of their carotids. And so that could be a cause. So too much antihypertension meds Okay? Another thing is if they go into like a shock, like a cardiogenic shock, a septic shock, some kind of shock where they're not able to give good maps, good perfusion. And on top of having low maps or low perfusion, you also have a big fatty plaque that's already obstructing that perfusion. That makes it worse. So if someone goes into some type of shocky state, and again, that could be septic shock, cardiogenic shock, doesn't really matter. Either way, there's a drop in blood pressure. Another common scenario is cardiac surgeries. So sometimes this is kind of common on your boards. So think about cardiac surgeries as another potential indication. So sometimes within these cardiac surgeries, you can also have these events, especially if you have a critical ICA stenosis. All right, so the next one that we want to talk about here is thrombus, right? So thrombotic causes of acute ischemic strokes. So thrombotic causes, here's what I want you to remember. There is risk factors for thrombotic strokes, and we'll talk about those in a second, but what I want you to know before that is where these thrombi are prone to forming. So let's talk about that. So these thrombi that we're going to discuss are very common in what's called large vessels, and we'll denote which ones I mean by these large vessels. These large vessels that can form thrombi, so large vessel, we'll put large vessel thrombi, or thrombus, is usually going to be your internal carotid artery. And you know your internal carotid artery, there's actually two parts of it. There's ones that actually are outside of the skull, the extracranial ICA, and then the ones that are inside of the skull, the intracranial ICA. So remember, both of those are large vessels. Another one is the middle cerebral artery, but particularly we got to denote that it's more particularly the proximal portion of the MC, like the M1 segment, not the M2, M3s. Those are less common to form these plaques and thrombi. And the next one here is your posterior circulation, so your vertebrals and your basilar arteries. These can form these nice fatty plaques there from a couple different risk factors we'll discuss, and then they can rupture, fissure open, form thrombi on them. So remember, these particular large vessel thrombi, particularly with these vessels. The other ones are your small vessel thrombi. These are not as high yield, but you should remember them. They're these tiny little vessels that come off of the middle cerebral artery and supply your basal ganglia. You guys know what they're called? They've got one heck of a name. They're called the lenticulostriate arteries. What are they called? They're called the lenticulostriate arteries. They're these tiny little vessels that feed the basal ganglia. They can get a lot of plaques within them that can fissure, rupture, and form a thrombus or a clot there and decrease blood flow to the basal ganglia, leading to strokes. The other one's not as significant, but you have these small pontine branches. These small little pontine branches are prone to a lot of these plaques to develop and then again form thrombi, leading to tiny little strokes within the pons as well. Okay? So these are the big things to remember. Thrombotic causes can affect large vessels. Those are the ones I really want you to remember. ICA, extracranial, intracranial, proximal MCA, vertebrobasilar. Small vessels that can form thrombi is lenticulostriate, more significant one, lesser degree, small little pontine perforators. We have to explain particularly now what causes these thrombi to form. We didn't talk about that yet. So there's particular things called risk factors. So I want to talk about primarily the risk factors that you can modify, okay, because that's the things that we can treat later on. And those particular risk factors that can lead to thrombi is hypertension is going to be the most common cause. I want you to remember that, okay? The second one that I want you guys to remember is diabetes. So diabetes mellitus, whether it be type 1 or type 2, that hyperglycemia is no bueno. Another one is hyperlipidemia. Hyperlipidemia can also lead to fatty plaques. The other is smoking. And last but not least, as modifiable risk factors, is obesity. If you guys want to know, the most important and common non-modifiable risk factor is old age, greater than 65 years of age, as well as being male, having a family history, things like that. And adding on to that, hyperlipidemia can be acquired and it also could be genetic too. So another potential non-modifiable risk factor, for the most part, is maybe some type of genetic hyperlipidemia that's really difficult to control with statins and other medications. So again, We know thrombotic causes are really due to these particular risk factors, and these thrombotic vessels are particularly these vessels. Now we have to explain how these risk factors lead to thrombi. So what happens here? These things here that we all talked about here, these risk factors, what they do is they lead to these atherosclerotic plaques. These atherosclerotic plaques you see here within the vessels. They lead to this fat little cheesy material that really accumulates here and starts to kind of cause stenosis and somewhat of an occlusion of the cerebral vessels. Okay? What happens is that maybe because of you having some high blood pressure, something like that, you fissure a little bit or rupture or break off a piece of that kind of covering of the plaque and expose the inner cheesy material of that plaque. And you know this inner cheesy material? It's super thrombotic, crazy thrombotic. Little platelets love to adhere to this. And that's what will happen. Platelets will start to adhere to that little cheesy material there and start to cause a lot of platelets to adhere here. And then on top of that, what starts to hold and kind of anchor down that platelet plug? Your fibrin, right? So then you get that fibrin mesh that also forms on top of that. So these risk factors lead to atherosclerotic plaques. If the plaque rips, fissures, ruptures, opens up, exposes that cheesy material, platelets adhere, form a platelet plug, fibrin covers it. Now look what you got. You got a clot on top of the thrombus. Can I get blood flow? If I had a neuron, a little baby neuron just sitting right here waiting for oxygen. Hey, give me oxygen. No. You can't get it, buddy, because I got this big whopping thrombus there blocking the blood flow there. So that is the thrombotic causes. Whew, that's a big one, right? All right. The next one that you guys need to remember is the embolic causes. Embolic causes are by far going to be the most common causes for acute ischemic strokes. And they can be broken down into 3 different categories. The first one is arterial to arterial emboli. It's very simple. You have 2 big vessels, okay, that are extracranial. Your extracranial ICA, let's denote this one here. This guy right here is your extracranial internal carotid artery. And then this bad boy right here that you have coming up here is your aortic arch. So over here you're going to have your aortic arch. What can happen is that you see these little plaques here that they have. These plaques, let's say that again, similar concept. You rupture, you fissure, you break off a piece of that plaque. Now that plaque that was stuck and adhered to the wall is now freely circulating. What is that called? An embolus. And so now that can go up through your cerebral circulation via your ICA or via your vertebral circulation and get stuck in one of these vessels, lead to ischemia, if not treated, infarction. Same concept here. In the ICA, what happens? You break off a piece of that plaque, it then freely circulates as an embolus, gets stuck in a further cerebral vessel. Important to remember. So, arterial to arterial emboli, they're not as common, but what happens is this could be due to an ICA plaque, or less common, it could be due to an aortic arch plaque. And all that happens with these is that you have the plaque on that vessel wall. The plaque that's on the vessel wall will rupture off a piece of the plaque. So then you'll get a piece of plaque that's going to be freely circulating now, and then that is going to get stuck in a vessel, and that's going to lead to, eventually, if untreated, an infarct to that cerebral tissue. All right, but boom, we killed that one. The next embolic cause, very, very important one that you guys need to remember. If you guys don't remember all of these, please, for the love of goodness, remember the cardiac embolus causes. Cardiac emboli, what are the big ones? Think about the atria, think about the ventricle, and then think about the valve. All right, so let's write that down then. So let's think about the left atria, the left ventricle, and then the valves. So we'll put down here left atrial thrombi that form there. So you form like a left atrial thrombus that occurs here somewhere in the atria, and then eventually it breaks off and then freely circulates, becomes an embolus. What are potential reasons that you can form a thrombus somewhere within the atria? Think about it. What if someone has a very dilated atria and they have like this quivering kind of activity there that they're not actually completely pushing blood out of the atria into the ventricles? So there's not an effective atrial contraction because there's an arrhythmia there. I'm already giving it away, right? So atrial fibrillation, we'll denote that as AFib, or atrial flutter to some degree as well, okay? The other thing is, what if there's a problem with the valve? So you got a valvular issue there, and there's a clot that's kind of forming near on the inner surface, the atrial surface of that valve. What could be a potential reason there? What if you have a mechanical valve? That could be a potential cause. So if you have a mechanical valve, oh man, that's definitely problematic. What if you have like some type of rheumatic heart disease, and these valves are like super prone to forming clots as well? Or you have infective endocarditis because you are an IV drug user, or you got a dental work and you ended up with an infection that spread to the heart, okay? These are all potential indications of forming a left atrial thrombus. Anything that leads to stasis of blood flow, hypercoagulability, or endothelial dysfunction increases the risk of clots. That's called Virchow's triad, right? What else? Left ventricular thrombi. So this one is kind of, again, similar. What if somebody had a really bad MI? They had a significant myocardial infarction. They knocked out a good chunk of that left ventricle, and it starts to become weak. And then it forms like a little sac, if you will. Like for example here, let's say that for example, when someone has a really bad MI, they kind of develop this little divot here, where it's easy and prone for a lot of clots to form within that divot. What could that be called? A left ventricular aneurysm. So if someone has what's called a left ventricular aneurysm, that could definitely be a cause. Another thing is, what if their ventricles, they had a significant MI that knocked out a good chunk of their entire like anterior and lateral portion of the heart? So they had a very significant, maybe anterior and lateral MI. That's going to cause a stasis of blood flow, because that controls like almost 60 to 70% of your pumping function. If you can't pump 60 to 70% of the blood out of your left ventricle, blood's going to sit there and it's going to lead to clots forming. And the other thing is, what if you have heart failure and you have CHF? So you have what's called heart failure with a reduced ejection fraction. And particularly, I'm talking low EFs. For example, maybe we're talking like 30 to 35%. Usually less than that is where you start having increased risk of thrombi forming, because you're not ejecting enough of the blood out of the heart. Okay, so these are just some of the many kinds of different causes, but these are the big ones that I want you to think about. How does this happen? It's very simple. Here's a clot here that's in the left atrium. For some reason that breaks off, goes into the left ventricle, or the clot in the left ventricle, or here. It's either in the atria or it's on the valve. These break off. They come into the left ventricle, or the clot from the left ventricle breaks off. Where does the blood from the left ventricle go? Up into the aorta. Where can it go from the aorta? It can go up through the carotid system, get stuck into a cerebral vessel, cause ischemia, if not treated, infarction. But boom, we got it. Okay, last embolic cause here is a very interesting one called a paradoxical embolus. So this one is actually due to what's called an atrial defect, is the basic way of saying it. So this is caused by an atrial septal defect of some kind, right? And there's really the most common one is a PFO, so a patent foramen ovale. Another one could be what's called an atrial septal aneurysm. But by far the one that I want you to remember here is going to be the PFO. All right, so what happens with these? There's a hole, an abnormal hole that forms between the atria, between the right atrium and the left atrium. There shouldn't be a hole there. What's the structure called that's usually between there? The fossa ovalis, right? Let's say that someone develops a DVT, right? So they get a DVT, which is a clot within the lower extremity. That clot breaks off from one of the vessels in the deep veins of the leg. Within the deep veins of the leg, they eventually will come up via the IVC. Via the IVC, they will enter into the right atrium. Normally, what does DVTs lead to? PEs. But if someone has a PFO or an atrial septal aneurysm, these can just go right into that little hole there within the atrial septum and then come over here from the right atrium, whoop, into the left atrium. From the left atrium, it's just as if a thrombus was forming there. And now this can float down, float up, get stuck in the cerebral circulation and lead to an ischemic stroke. So it's important to remember these as potential causes. Last thing I need you guys to know is that we talked about locations for thrombotic causes, the large vessels, small vessels. We talked about how global hypoperfusion affects watershed regions. The embolic causes, so embolic locations, if you will, are very important to remember. So usually embolic locations include your MCA, okay? So the middle cerebral artery. Usually it can be like the proximal stem of it. For example, like the M1 segment, the proximal stem of it. You can also get this in your PCA, okay? And this could be in the main part of the PCA, but here's where it gets a little bit interesting. They could also branch down further into the further segments of the MCA and the PCA. So the smaller segments. So for example, just as an example, your MCA has like M2, M3, like, different types of segments that you could actually throw a little clot into, that thrombotic causes don't usually occur in these tiny little cortical vessels, or maybe a P1 or a P2 vessel that they get stuck in. So it's kind of just that kind of example. It's little small cortical vessels that are extreme small branches of these large vessels, okay? So very important to remember that embolic locations, you can have a couple things. One, in these locations, and also you could have a stroke in MCA and a PCA, because when you have emboli, you could have multiple emboli that go and decide to float into the MCA circulation, and maybe another one decides to float into the PCA circulation. So if you see someone with a stroke on their imaging and they got strokes all over the place, potentially think about an embolic cause, okay? Anyway, off our soapbox into the other rare causes that we should just think about but don't dwell on them. All right, the other causes that I want you guys to be thinking about is the other rare causes, so vasculitis, dissection, and hypercoagulable disorders. You should think about it because you don't want to miss it in case it's not one of these. So vasculitis, so there's a couple different types, right? So when we talk about vasculitis, it could be autoimmune. Okay, so there is a couple different types of autoimmune vasculitises. Think about Takeyasu's, think about giant cell arteritis, right? The other thing is it could be infectious. And so when we talk about infectious, there's mainly three types there: tuberculosis, varicella zoster virus, and syphilis. Syphilis can do really anything, can't it? And then the last thing is if it's just what's called a primary CNS vasculitis. And so don't worry too much about that one. That usually requires a lot more thorough evaluation. But big thing is these three particular types of vasculitides, these are the causes. Now, how does vasculitis lead to a stroke, I guess, is a good question, right? So what happens with any of these causes, whether it be due to, let's say we have like here, we have like a pathogen of some kind, or we have like, antibodies from an autoimmune cause, these love to attack the cerebral vessels, right? And what happens is when you attack these cerebral vessels, it leads to inflammation. That inflammation does what? Well, sometimes it could just basically, if you get a really thick inflamed vessel wall on both sides, it could narrow the vessel a little bit and they kind of really narrow the lumen. But another thing is, think about this. When you injure endothelium, because that's what you will do with these pathogens or with these antibodies, what are you going to do if you injure the endothelial cells? You increase the risk of clots. And so if you form a clot on this like vasculitic kind of bed here, what can happen? You can occlude the actual blood flow beyond that and lead to some ischemia, and if not treated or reversed, infarction, okay? What's another cause? Dissection. So dissection is usually kind of due to trauma. So it's usually some kind of traumatic event. And this can occur, in your vertebrals. This can occur in the carotids, very common locations for those to occur. If it's smaller ones, like really, really tiny ones, it's usually an iatrogenic cause. So, for example, if you're going in to retrieve a clot from somebody and you start threading that catheter down further, and maybe you just accidentally hit the endothelial lining and tear it, well, then you can create a dissection, and that can allow for blood to kind of track between the endothelial layer and the tiny little muscle layer there. The other one is you think about connective tissue diseases. If there really is risk there, the connective tissue, the internal elastic lamina and the different types of tissues there are a little bit like not present or they're defective, there could be a little bit more risk of you actually easily rupturing those vessels. So think about things like Marfan syndrome, Ehlers-Danlos syndrome, things like that. But how does this happen? So again, it's very simple. Whether there's any of these things, you kind of just break through that kind of vessel wall lining, the endothelial lining, the tunica interna, intima, and allow for blood to track in through that in between the media and the intima. So it can actually kind of move like side to side in this area here. And if blood kind of sits in between the tunica media and the tunica interna and it just kind of accumulates, think about it just like you're filling a balloon, it's going to bop, 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 and eventually this whole thing is going to include this lining there as blood kind of fills within that little space there. And that can lead to ischemia if not corrected, infarction. Last but not least is your hypercoagulable disorders. So hypercoagulability is you increase the risk of forming clots, right? So there's your hypercoagulable cause within that Virchow's triad. So when we talk about these, they aren't too common, and actually, believe it or not, they're more likely to cause venous clots than they are likely to cause arterial clots, but you should still think of them because they can cause acute catastrophic arterial clots. So what would be some of the causes here? I don't want you to get bogged down on them, but a couple of them include factor V Leiden. So it's called factor V Leiden is a very common one. Another one is called protein C and S deficiency. Another one is called antithrombin 3 deficiency. Another one is called the prothrombin gene mutation. Oh, there's so many dang things here, right? So prothrombin mutation. And another one is called like antiphospholipid syndrome. So there's another one. A couple extra other kind of rare ones is like polycythemia. So in this kind of condition, you make a little bit too many red blood cells and you can really make the blood viscous and clot up those vessels. You know, if someone gets heparin, is what's called heparin-induced thrombocytopenia. That also can lead to like this paradoxical clotting that can occur, even though it doesn't make sense sometimes. That's why it's called paradoxical. So heparin-induced thrombocytopenia is another hypercoagulable cause, and that gives us what we need to understand the etiology and pathophysiology of acute ischemic strokes. Now let's go over and briefly talk about the clinical features. All right, so let's talk about the clinical features involved in acute ischemic stroke. Now, we're not going to go into crazy detail because if you guys haven't already, please, for the love of goodness, go watch our video on stroke syndromes. We thoroughly evaluate all of the neurodeficits that come from acute ischemic strokes. And that's going to be really, really important. Okay, so please check that out. We'll have a link right here to go check that out, okay? All right, but to breeze over that, because you guys have already watched that, clinical features dependent upon the vascular territory that gets hit. For example, if you knock out this portion here, the anterior cerebral artery syndrome, there's particular symptoms. The MCA syndrome, the PCA syndrome, and a little bit of the combination, the ICA syndrome, that you can get kind of a mixed MCA and ACA, as well as the amaurosis fugax that we talked about. The other ones that I did want to kind of briefly talk about, because we talked a little bit about them with global hypoperfusion, is watershed areas. And that's basically these areas where the MCA and the PCA meet, called the MCA-PCA watershed zone. Sometimes in global hypoperfusion, it can knock out that area, or the MCA ACA watershed zone can get knocked out in global hypoperfusion. We also in that video talked about the stroke syndromes involved within the brainstem. Remember, PCA syndrome can involve the midbrain. The basilar artery syndrome can hit your pons, and then there's little feeders that come off of it called the ICA and the superior cerebellar artery that involve the cerebellum, the superior and anterior portion of the cerebellum. And then your vertebral arteries are going to be involved. If they get hit, that can affect the portions within the medulla, as well as the feeders that come off of that, which include your pica, which hits that posterior and inferior portion of the cerebellum as well. So again, watch that video on stroke syndromes. It'll give you a nice little recap of that if you guys need to understand the clinical features. Now that we have a basic rundown of clinical features, let's run through the really important stuff. I don't want us to get bogged down in all this excessive details. I want us to think about these other things, but the most important thing you need to do when someone you suspect has an acute ischemic stroke is get some imaging. What imaging do you need? The big thing to obtain is a stat CT scan, and particularly in like a non-contrast. You don't really need contrast unless you really want to. We can talk about why you could get that. But a stat CT scan, and really what I want to do is, if someone comes in with neurodeficits or strokes, you guys need to remember that strokes, there's not just ischemic strokes, there's hemorrhagic strokes. So intracerebral hemorrhage, subarachnoid hemorrhages, those can also present like a stroke. So it's important to remember, we get a stat CT scan to rule out that this stroke is not due to an ICH or it's not due to a subarachnoid hemorrhage. The second thing is, if we do get the stat CT and you're good at reading CT scans, you may be able to pick up some things called hyperdense signs. And these can show up as a hyperdense MCA, like a fresh clot that shows up bright on the CT scan within the MCA or within the basilar artery. Okay? Other things that you could look for, and again, this is for the vessels. When someone's infarct, they have an ischemic infarct, and let's say that they have these neurodeficits, and it's a little bit later, and that infarct has already completely like hit that entire territory, and it's evolved, it may show hypodensities as the infarct, okay, to the tissue, the cerebral tissue. It may show darker than other parts on the CT scan. I did say that you can get other images called a CTA, and we'll call that a CT angiogram, which is basically a CT scan with contrast. All that does is it fills up and brightens up those vessels in the brain. And the reason why you would do that is if you find out that they don't have an ICH or a subarachnoid hemorrhage, then what can you do? Maybe if you don't pick up the hyperdense sign, maybe if you're not good enough to pick up the hypodensities, you push contrast through those vessels, you'll see where the contrast can't get past that clot. And so this will show you like a filling defect maybe, or like where the occlusion is. And that can key to, oh, that's where it is, and that tells me where it is as well. Is it in the MCA, the ACA, the ICA, so on and so forth. So it's a pretty good thing to think about. Afterwards, you shouldn't do this acutely. This is the big stuff. If there's anything that you take away from the diagnosis, for the love of goodness, don't forget this. But afterwards, after they've been treated acutely, later you can obtain an MRI. MRIs are good for giving you a little bit more sensitivity and definitive diagnosis of the infarcts. CTAs are great, but MRIs will be very helpful. And the reason why is there's two parts to that, and there's the DWI sequence and the ADC sequence within the MRI of the brain. What the DWI shows is that if you have an ischemic infarct, it'll show up bright. So we call that hyper, now get ready, we call it hyper and hypodense for CT, we call it hyper intense on an MRI. On the ADC, it shows up dark where the infarct is, and it should correlate to the same location you see on the DWI. And if it's dark here, what do you think is going to be here? Okay, if it's bright there, it's going to be dark here in the ADC. So hypo intense. So again, to recap that, DWI, where the infarct is, it'll show up bright, hyper intense. Look at the ADC, in that same area where it was hyper intense on the ADC sequence, it should show up dark or hypo intense. Okay, that's our soapbox for the CT, CTA, MRI. Those are the big images that you need. What are some of the other stuff? Okay, once we've diagnosed, this is basically, we've diagnosed acute ischemic stroke at this point. We could stop and move on to the treatment. But if we want to be true awesome ninja nerds, after we've diagnosed them and we started to acutely treat them, we should start thinking about what caused their stroke. Because do we want them to have another stroke in the future? No. So we got to find out what caused their stroke. And that's where the rest of these diagnostics come into play. So the next thing I would encourage someone to do is to obtain a echo. Okay, so to obtain what's called a esophageal echo, that's kind of the ideal scenario, but transthoracic echo is also very valuable. What does this do? This gives you a look at the heart. What should you think about when someone has a stroke? What did I tell you is one of the most common causes? Embolic causes. And where were those embolic ones that I told you? If you don't remember it, if you forget everything else, please don't forget these ones. cardioembolic. So the echo looks at the heart and looks to see, is there any atrial thrombi, any ventricular thrombi, is there any vegetations on the valve? So this will give me a good look. Do they have AFib, right? Or I should actually be more specific, do they have a left atrial thrombus? That left atrial thrombus could be due to AFib. So do they have a left atrial thrombus? And then another thing that helps us is the atria dilated? Usually if the atria are dilated, that's probably a good sign that this person has atrial fibrillation, because dilating the atria definitely leads to atrial fibrillation. But also, do they have a left ventricular thrombus? And another thing that's nice about this is echoes will give you your ejection fraction and look for motion, wall motion abnormalities. So is there any wall motion abnormalities? Because that may tell you that if they have a wall motion abnormality, that maybe they had an infarct of that portion of the heart. They had an ischemic attack there. Or it tells us our ejection fraction, our EF. And maybe this person's EF is really low, and we use the example of 30 to 35%. As we get less than 35%, it's getting a little low. Maybe that's the reason for their cardioembolic cause. Boom, roasted, move on. Another thing that we can think about, it just helps in aiding in the cardioembolic cause, because that's one of the most common ones to think about, is getting an EKG. Correlate your echo with your EKG or your Holter monitor or your telemetry readings. Think about these. So if someone has on their EKG, so let's say that you obtain a 12 lead EKG, maybe you don't pick it up on that. Maybe you put them on a continuous monitor like a Holter or a telemetry monitor, and you pick up, oh, I see that they got AFib. Or, oh, I see that they got atrial flutter. Or, oh, I see that they got maybe like some N-STEMI. Or maybe they got some Q waves. Or maybe they even have a STEMI, who knows. But we kind of see, oh, I see some reasons of why they may have this cardioembolic cause. It just aids in the diagnosis, you know? All right, we hit these. What are the other stuff that we should think about? Let's get into the quick little easy labs. All right, so remember, at this point, we've obtained the most important kind of imaging, which is that stat CT, we got the CTA, we got an MRI a little bit later. Later on, we got an echo. We got our EKGs to kind of help to assist in what was the cause of the stroke, but that CT scan and the CTA were really the most important things. And the same thing for the labs, there's a really important lab that you need to get. Really kind of two labs, really, if you really want to take it to the extra mile. But really important one that you cannot forget to do is what's called a point of care glucose. And all that means is you just tell the nurse, hey, can you go into the room, use that glucometer and tell me what their glucose is. The reason why is we want to know, are they low glucose, hypoglycemia, or are they high glucose, hyperglycemia? The reason why is that sometimes hypoglycemia, and to a lesser degree, hyperglycemia can present as stroke mimics. Gotta make sure that before I give them TPA, are they actually having these kind of weird symptoms because they're hypoglycemic? Also, another important thing is that if someone has low glucose, you need to make sure that before you give them TPA, you correct the glucose. Okay? You can't have hypoglycemia before you give TPA. It's just a part of the requirements. The other things that you'd want to do, a little bit less significant, I think this is a really, really big one, but another thing is check their INR. And the reason why is you can check the other coags. For example, you can check PT INR, and you can even check a PTT. But really the most important one out of these is your INR. So if someone has an INR that's technically greater than 1.7, and let's say that they're taking warfarin, we have to take that into consideration when we give TPA, because if they're being anticoagulated and I give them TPA, that may increase their risk of bleeding. So I have to think about that. So sometimes getting an INR may be helpful as a part of your coagulation studies. The other thing to think about here is maybe obtaining a CBC. So a CBC, the only reason I think that this would be a helpful one is to really see if the person's like bleeding. Maybe you don't see a visible bleed, but you check their CBC and they're significantly anemic. That may be an indication. Also, if you want to take it the extra mile, what was a hypercoagulable cause that's the exact opposite of anemia? Polycythemia. That may help you in your diagnosis. Again, not big important thing to do right away, but a little bit later, getting that CBC, CBC for anemia is the big thing because maybe they're bleeding, so that can affect TPA, but polycythemia may be a diagnosis for their cause of stroke. The other thing is thrombocytopenia. So do they have low platelets? Okay, because having low platelets, like less than 100,000, can also be somewhat of a contraindication to giving TPA, so it's something to think about as well. So the big things for these labs is checking to make sure that they're hypoglycemic because it can cause a stroke mimic. Also, when you give TPA, you can't be hypoglycemic. Also, coags, making sure that they're not having elevated INR so that they're at a high bleeding risk from maybe taking warfarin or like a liver coagulopathy. Checking your CBC to look to see if they're bleeding. Maybe you can see some signs of anemia. Or low platelets, thrombocytopenia, because that can affect giving TPA. Low on the list of tests. Not super concerned because some don't even really consider this at all. Is checking a BMP, and the reason why is to look to see if someone has a high creatinine or high BUN. The only reason why is that this may determine whether or not you give someone contrast, but if you're going to give someone contrast because they need the study to determine if they're having a stroke, I think that supersedes their elevated creatinine BUN. So again, these are some of the basic tests to think about. The other ones I think that you should be aware of a little bit later, after you've acutely treated them and stabilized them. Maybe if someone is having like a STEMI or an NSTEMI and stuff like that, they're having some signs of ischemia from the heart. Their heart may be leaking particular cardiac markers that could be another sign aiding in maybe a cardioembolic cause. And that would be where you want to be checking troponins or checking CKMB, but mainly the troponins, and seeing if these bad boys are elevated. Because maybe you're leaking these types of things from the actual heart tissue because you damaged the heart tissue. That could potentially aid in the diagnosis. The other thing that's actually really interesting, was taught to me by an attending, was that sometimes if someone doesn't have AFib that's on their EKG, on their Holter, you don't see like a dilated atrium, you don't see any thrombi in the heart, check a TSH. And the reason why is sometimes if someone has a low TSH, but a high free T4, they have what's called hyperthyroidism, but we'll call this thyrotoxicosis. When someone has really, really bad hyperthyroidism, that really can stimulate the heart and put it into overdrive. And guess what it can do to the heart? It can cause the heart to start developing these abnormal arrhythmias and leading to what's called atrial fibrillation. So another thing to be thinking about is, are they hyperthyroid? And maybe they do have AFib. Pretty cool thought. So that covers that. The last thing that you should think about for the quick little easy labs here, actually, these are the big quick easy labs. The other stuff is a little bit more kind of involved, maybe take a little bit more time. If you think, for example, they're young, so you have like a patient like less than 50 years old, and they have this acute ischemic stroke, and they have had a history of multiple DVTs, or they had a history of multiple pulmonary embolisms, or things like that. They're just, you think that there's something weird, they may have a hypercoagulable condition, do a hypercoagulable workup. So what does that include? Oh, we don't want to go through all of these, do we? We won't. We're going to mention a couple, see if you guys can remember. What was the big one that I want you guys to remember? Factor V. Do they have low factor V? What was the other big one I want you to remember? Maybe protein C and S, right? Is that one low? Do they have low antithrombin 3? Do they have antiphospholipid syndrome, so on and so forth? And there's other ones, right? We said heparin-induced thrombocytopenia, polycythemia, prothrombin gene mutation, all of these different things that we can order, but do it if you suspect it because they're younger and they're throwing other clots in other areas of their body, particularly like venous clots. The other stuff is more, again, this one's a little bit less, this last kind of workup should really, really be low in your differential and your workup here. But this one's kind of an important one. So what's causing their plaques? Do you guys remember? What were the risk factors? Hypertension. You can just check their blood pressure when they're coming in. If they're really high, that could be a risk factor. We already kind of notate that. But what else? What if you check their hemoglobin A1C? And they have a very, very nasty hemoglobin A1C. And they haven't had very good blood sugar control. Maybe that keys into them having diabetes. And you need to think about that as the reason why they're developing these big old fatty plaques in their vessels, and then when it ruptures and fissures, it leads to those thrombotic causes. Other things is check a lipid panel. Do they have a lipid panel like one of our Ninja Nerd co-founders, Rob, where they have elevated LDLs? Or they have maybe low HDL, which again, they're not able to pull those plaques from the vessels. And sometimes there could be a hereditary cause. So maybe you throw in like a lipoprotein A as a potential cause for like a hereditary thing. But I think these are some of the big things. So do they smoke? Are they obese? Things like that. Those are other risk factors, but these are the ones that you can get quick little labs on. Some people even order like homocysteine levels as well. I think these are the big things to think about. Hemoglobin A1C, lipid panel. For the other stuff is your vasculitis. And this is why I was saying this should really be low. I don't really want you guys to spend a lot of time. To be honest, if you guys want to skip to the next part of the video, I'm fine with that. But vasculitis is really low on your differential. The ways that you can kind of go about checking this one is start off, is it autoimmune? Maybe you just start off with an ESR and a CRP. And those are elevated? Okay, well maybe I'll take it to the next level and I'll check like some ANCAs and I'll do like an ANA panel and stuff like that for autoimmune causes. Maybe you suspect infectious causes. So maybe you go ahead and you go straight for, they have a abnormal like sexual history and you want to check for syphilis, VDRL, RPR. Maybe you want to check for varicella zoster virus because they had a history of shingles or something like that. So you check a PCR of their varicella zoster. Maybe you suspect TB, so you can go through all the TB tests. Maybe you check a chest x-ray. Maybe you check the quantiferon assay. And then primary CNS vasculitis. Sometimes this requires a way more thorough workup, and sometimes you really kind of need like a biopsy really to get to that point. So again, you can see why not too big, but we need to be thorough here at Ninja Nerd and really think about the causes. But big things to take away: stat CT, point of care glucose, coags, CBC are the big diagnostic studies. The other stuff will aid in thinking about the cause of the acute ischemic stroke. Let's hit treatment. All right, Ninja Nerds, we're at the last part of the lecture, which is very important. So we got to start acutely treating this patient who's coming in with some neurodeficits. Okay, we got that CT scan. We found no bleed. We suspected maybe a hyperdense sign. We got the CTA. We found the occlusion. Now we got to start treating this person. We made sure that they don't have an ICH. We made sure that they don't have a subarachnoid hemorrhage. We made sure that their glucose wasn't low. We made sure that their coags were fine. Make sure they're not bleeding on their kind of labs there. What do we got to do? Give them the TPA. But when we give TPA, what should be the reason why we give the TPA? Let's think about this. Mechanistically, TPA is kind of an activator of plasminogen. What the heck is plasminogen? So plasminogen is like a little enzyme, right? That's present, kind of circulating in the blood. And what TPA does is it helps to convert plasminogen into an enzyme called plasmin. And what plasmin does is it acts on the fibrin within the actual kind of blood clot and starts shiatsuing that fibrin and breaking down the clot to bust the clot up. So again, what is TPA really doing? TPA is stimulating this process here. So we know now how the TPA works because it activates plasminogen into plasmin. Plasmin breaks down the fibrin within the fibrin mesh, helping to dissolve the clot. Now we have to think about indications. When do you give the TPA? All right, so indications to be giving TPA include having a neuro deficit. We didn't talk about this, but whenever you're doing a neuro exam and you're thinking about the person's clinical features, you utilize what's called the NIH stroke scale, the NIH-SS, and you're basically giving them particular scores on what deficits they have present. Sometimes the guidelines say you need like an NIH stroke scale score greater than 4 to really be able to get TPA, but if you have neurodeficits, that's really what I want you to know. You have neurodeficits, but NIH stroke scale scores sometimes greater than 4 is preferred. So we look for them to really have neurodeficits. I wouldn't get too caught up on the score. Okay, second thing that you need is you need them to have no ICH and subarachnoid hemorrhage on their CT scan, their non-contrast CT scan that we had. That's an important thing. And the next most important thing is that you know their last known well. This can sometimes be a little bit difficult and a little tough. You need to know, when was the patient normal? They didn't have those neurodeficits. I need to know the exact time. The reason why is that there's two kind of categories for this. There's less than 3 hours, and generally within this we give the TPA. No problem, hit them with the TPA, baby. But if it's like 3 to 4.5 hours, we have to be a little bit more stringent with the TPA. And so we need them to have no history of diabetes or previous stroke. We need them to be greater than 18 years old. We need them to have, this is where the NIH stroke scale score kind of comes in, an NIH stroke scale score of less than 25. And we need, if they do have an infarct, that's already kind of showing there, it's less than 1/3 of the MCA territory, or if there's ischemia of that, it's less than 1/3 of the MCA territory. If you meet all this criteria as well as the following above, give them the TPA, baby. Okay? So that's the big things. Now there is a lot of other contraindications. We kind of blew past them. Again, making sure that their glucose isn't low. If it is hypoglycemia, give them glucose. Making sure that they don't have any active bleeding from anywhere in their body, whether it's in the brain, whether it's from the GI tract, whether it's from any other traumatic incident. Make sure that they're not bleeding, because if they're bleeding, you can't give them TPA. Another thing is blood pressure. And we'll talk about blood pressure control. You prefer to give someone TPA with a blood pressure less than, there's two different goals. A lot of the goals will say less than 185 over 110. Some will even say 180 over 105. Just go with the less than 185 over 110. That's kind of like the standard number. That would be another reason, oh, their blood pressure is too high, lower it and then give them the TPA. So there's a lot of contraindications to this, but I think the biggest things to think about is, do they have neurodeficits? Do they not have a bleed in their brain or any other blood coming from any other part of the body? Their last known well is well documented here. Give them the TPA. Okay, I think that's the big thing to think about here. When you give TPA, it's important to remember that when you give TPA, the dosage is actually kind of a standard dosage, like 0.9 milligrams per kilogram. You give 10% as a bolus, and then you give the remaining over like the remaining hour. The other thing is, again, post-TPA, we'll talk about this, blood pressure goals are very important. But after someone has had like 24 hours post-TPA, we need them to obtain a CT scan, because we want to make sure that they didn't like convert, or we just want to have a good idea of what their scan looks like after they stroked. Okay, and then they probably need to go to an ICU so they can have good monitoring and frequent neuro checks. Okay, what is another treatment option? So let's say that someone comes in, they have neurodeficits, they don't have an ICH or subarachnoid hemorrhage on their CT scan. They last known well is a little bit beyond 4.5 hours. Maybe we're at 6 hours. So mechanical thrombectomy is very interesting. So basically what happens is, this is an interventional radiology type of procedure. And what they do is they take and they feed like a catheter up here, and they can do two things. One is they can use this catheter and they can suck out that clot, or they can put like a stent in there and then retrieve the clot. So it's one or the other. So either use what's called a stent retriever or like an aspiration device. But either way, when someone's getting a mechanical thrombectomy, the indications are pretty much relatively the same as giving TPA. We need neurodeficits to be present. We also need no ICH or subarachnoid hemorrhage, but we can also change our time frame. Okay, there's two parts of the time frame. I'll explain what I mean. If you're in 6 to 24 hours post, like last known well, so 6 to 24 hours from the last known well, you still fit within the window of getting a mechanical thrombectomy. It is preferred that you try to get there less than 6 hours or at the 6 hour mark, because time is tissue. The longer you wait, the more tissue is being damaged and the less penumbra is present to be salvaged. What the heck is a penumbra, Zach? You never talked about this. So whenever you have ischemia, you can infarct a particular, like a core of the brain tissue. Around that core, there may be still tissue that's ischemic and it's getting ready to infarct, but if you give them TPA, or if you do a thrombectomy and suck that clot out, you can save the tissue that's really suffering right now and it's ischemic and hasn't infarcted yet. So we prefer to keep it at that 6-hour range. If you start pushing towards these longer times, getting towards like close to the 24-hour range, we want to make sure, is there a salvageable penumbra? Such a weird name, right? And so this is where sometimes you can use what's called like different types of perfusion scans, like CT perfusion, MR perfusions. Sometimes people even use what's called like aspect scores and things like that. But we're using this to determine, is there a penumbra that we can even save? The other reason that we would do a mechanical thrombectomy is someone can get a TPA, they can get TPA, and they have a stroke, but do they have a large vessel occlusion? What the heck does that mean? Is there a clot in the MCA, the ICA, or in the vertebro-basilar system? If there is a clot in any of those, you can give TPA and do a mechanical thrombectomy. Okay, so I think we have a pretty good idea now for mechanical thrombectomy, TPA. These are your acute treatments. Get these things done, and then some of the other stuff we can kind of figure out. Okay, what's the next thing? I kind of contradicted myself, right? TPA, definitely, mechanical thrombectomy, very important, but always whenever you're treating somebody, it's always A, B, C's, airway, breathing, circulation. So if someone's coming in and they don't have a good airway, you should obviously control their airway. So airway, breathing, circulation first, but you still want to give the TPA. This is the acute treatment. So when we talk about airway, what do we mean? If someone has a decreasing level of consciousness because of their stroke, or because they aspirated because they have significant dysphagia from their stroke, then what do we need to consider? So if they have like a GCS that's less than or equal to 8, that may be an indication to intubate them and then responsively mechanically ventilate the patient to make sure that we're controlling their airway. Okay, so very important to think about that. The other really, really big one is blood pressure control. You need to have good blood pressure control in people who have strokes, particularly post-TPA or even if there's no intervention at all. So let's write that down. So if someone is status post-TPA, remember when they give TPA, you have to be less than 185/110. After TPA, usually for the first 24 hours after TPA, you particularly, there's again different goals. I'm gonna write them both down. And it's institution dependent, like 185/110 is kind of one of the goals there. 185/110. Some will even say 180/105. The difference there is very minimal, really. But when we talk about these, you want to have your blood pressure less than this after TPA for at least 24 hours. After those 24 hours, you can modulate it and it's modifiable there. But how do we base this? The next thing is, what if there is no TPA? So they don't get TPA. Then what? Okay, well then, I just gotta keep their blood pressure less than 220. Systolic blood pressure, I want that less than 220. That's good enough for me, right? If we start getting higher, that's not too great. So less than 220 is the goal for no TPA. If they're getting TPA, 185/110 or less than 185/105. How do we control their blood pressure? There's so many drugs that you can give. The preferable one within the first 24 hours, because you get the most control of it, is nicardipine, because it can come as an infusion and you get very good blood pressure control with this. Other options include IV labetalol, very relatively quick acting, and then the other one is like hydralazine. Okay, a little bit more variable in its effect, but these are some of the drugs. And there's other ones too, like antiplatelet, also known as Vasotec. Those are some other drugs that you can give. But you want to control their blood pressure if they get TPA or if they don't get TPA based upon these goals. So we got airway, we got breathing and circulation, we gave them the emergent TPA or mechanical thrombectomy. All the other stuff now is not as significant in the acute scenario. It's things to prevent and help afterwards. Okay, what's the next thing? Anticoagulation. Anticoagulation is important if somebody has a reason to be anticoagulated, like if they have a cardioembolic cause. So cardioembolic causes are very important things to remember. So if someone has a cardioembolic source of their acute ischemic stroke, for example, and we'll just throw in a couple of these. Maybe they have AFib, maybe they have atrial flutter, maybe they have a left ventricular aneurysm, whatever. They have one of these reasons and they need to be anticoagulated. What do you do? Acutely, if they're still like in the hospital, you get a little bit better like titration control with a heparin infusion. But once you kind of like get a good control of their anticoagulation, you can put them on something that's called a DOAC. And this is like, for example, just put one of them like a Pixaban. Another one is rivaroxaban. Or you can put them on warfarin. It kind of just depends on their cause. Like if someone has a mechanical valve or they have some type of valvular problem, usually warfarin's a little bit more preferred over something like a Pixaban or rivaroxaban. But this is our anticoagulation. Now, big thing to think about, please don't forget this, for the love of goodness, if they have a huge MCA infarct. So let's say that they don't get TPA, they don't get IR, and they end up like infarcting like their entire MCA territory. For the love of goodness, don't give them anticoagulation, even if they have like really bad AFib. You can convert that infarct into a hemorrhagic bleed. You don't want to do that, so you might have to hold anticoagulation for a while. And again, you don't anticoagulate them immediately after they stroke. You have to give it some time after they've gotten TPA or their intervention, and then after they're stable, you can give anticoagulation. The next thing that was on the list was that paradoxical causes, right? So you have a paradoxical embolus due to like a PFO or an atrial septal aneurysm. PFO is the big one I want you guys to remember. So with PFOs, sometimes there's like this question of should we anticoagulate them? Sometimes you can give warfarin or aspirin, one of the other. There was a study that showed no superiority of warfarin over aspirin in these scenarios. But what seems to be relatively helpful is doing what's called a percutaneous closure. Percutaneous closure of that PFO, so that you don't have any risk. So if they had a hole here and a hole there, right, a hole between the atria, just take a little thing there, close it up, so that you can't allow for any clot to freely circulate there. So that's something to think about there. Now, we hit our embolic causes, right, for the most part, the anticoagulation for cardioembolic and then the paradoxical one. Carotid revascularization is kind of revisiting those thrombotic causes. So remember we talked about the internal carotid artery. So this right here is this is our CCA, common carotid artery, and then this is going to branch into your ECA and into your ICA. And where do we say that plaques like to form? At that bifurcation where you go into the ICA or ECA, right there is where you start to form these like nice little plaques, right? Now, whenever someone has really bad stenosis, like really bad stenosis, so what am I talking about? So let's say that they had a stroke. So let's actually write that down. Let's say that they have carotid stenosis, and there's two things. One is they had a stroke. They had an acute ischemic stroke because of that. And on top of that, they have stenosis that is greater than like 70%. Sometimes people even do it less than 70%, but the best thing is if they have stenosis that's greater than 70%, they definitely need intervention. And the two primary interventions to be thinking about here is if someone gets what's called a CEA, I'm not going to spell this out, it's just too long of a name, carotid endarterectomy. What does that mean? You basically cut the plaque out. And that's all you're really doing. You're just going in there and cutting that plaque off of the vessel wall. The other one is going to be what's called a carotid artery stent. And this one's actually pretty simple. I can actually spell this one out for you. So carotid artery stent. All you do is you take a catheter, move this thing through the vessel, and then put a balloon in there to really push that actual plaque down, and then put a stent in there. And that helps to control that as well. Now here's the big thing to think about. When someone has carotid stenosis, right, really bad one, a critical stenosis like greater than 70, they have a stroke, so they're symptomatic, they should get one of these procedures. And there's different protocols and reasons why someone should get one over the other. We'll talk about that in a video dedicated to carotid stenosis. But for right now, what I want you guys to think about is if someone gets like a stent placed there, you need to be thinking about, do they need to get antithrombotics? So sometimes if they either are not getting treated or they're getting a stent, sometimes you need to put them on anti-platelet agents. And we'll talk about that with some of the risk factor modifications really, but antiplatelet agents is a big thing to think about, antiplatelets, especially if they get stents there, okay? Or if they don't get a stent, they don't get any intervention, sometimes you should give them antiplatelets because what is the cause? A thrombus. If that ruptures fissures, what's gonna happen? You're gonna form a thrombus on top of them. Give them antiplatelets to prevent those platelets from adhering to the actual area where that thrombogenic cheesy core is. Okay, that hits the big stuff there. The other stuff is playing into this kind of like plaque stuff, right? So if someone has this atherosclerotic cardiovascular disease and they have all these like nasty plaques within their vessel wall, what do we say were the risk factors that we can actually treat and modify? I know it's right here. Hypertension. How do you treat hypertension? I shouldn't have to write this down. Better blood pressure control. How do you treat diabetes mellitus? Better insulin, better control of their anti-diabetic medications. Hyperlipidemia, put them on statins. We'll write this one down here because this one is important to remember. This one is statins. Okay? Statins are very important. You should remember those. Atorvastatin, rosuvastatin, they need to be on high intensity statins. Smoking, stop smoking. Obesity, lose weight. And antiplatelets, going back to that anti-thrombotic thing, think about aspirin or clopidogrel. Sometimes, if they're having carotid artery stents or they have like a coronary artery disease with stents, sometimes they'll put them on dual antiplatelets, aspirin and clopidogrel. But again, thinking about these kinds of things is going to help you from preventing a future stroke. But remember, airway, breathing, circulation, acute treatment with TPA or mechanical thrombectomy. Now let's talk about potential complications that you have to be thinking about to treat. All right, so what else do we got to think about when we're treating someone for an acute ischemic stroke? Well, if you give them TPA, if they're within the window, you give them the TPA. Later on, when they're in the ICU and they're getting their neuro checks and they're getting all their post-TPA, kind of criteria that you have to follow, all of a sudden, maybe they were moving their right arm. They're not moving it anymore. They were kind of communicating with you. They're not communicating with you anymore. Get a stat CT scan. Maybe that infarct from you giving them TPA converted into a bleed. And so get a CT scan. So right away you get a CT scan, you see this big whopping bleed in their brain. Now what do? Besides go to the bathroom and change your underwear, you need to start getting quick interventions. If they're on TPA, still getting it, stop the TPA infusion. And if they're fibrinogen, you should quickly throw in a fibrinogen level. The reason why is if someone has low fibrinogen, you should reverse their TPA, especially if it's like less than 180. If you really want to go there, I'll write it down. Less than 180 milligrams per DL, you should reverse it. So how do we reverse TPA? What are the things that we give? The baseline stuff that you need to remember is you have to give what's called TXA, tranexamic acid. You give it as 1 gram bolus and then another gram a little bit later. And then the other one is cryoprecipitate. Okay, some people may only give the TXA, but cryoprecipitate has fibrinogen in it, so that may help as well. And sometimes the protocols even call for platelet transfusions, so you can even consider that as well. But these are the big things. Let's say you give someone TPA. The neuroscience ICU. Nurse comes and says, hey, Zach, they're really hypoxic now. Or, hey, they're having difficulty breathing. Or their face is like swollen. They look like Shrek. What do? I need to think about angioedema. This can happen post-TPA. Not super common, but think about it. So if you have them, you go in there and you see old Shreky there, what do? You give them antihistamines. Because it's a histamine reaction, right? So give them antihistamines. I just butchered the antihistamine. So you give them antihistamines like Benadryl, right? Also known as diphenhydramine. And you should also give them famotidine with that, even though it's not an H1RA, it's an H2RA, but it's involved in a histamine reaction. You should also give them IV steroids, things like methylprednisolone, 100 milligrams, and have a very, very low threshold to intubate them. The reason why is, think about it. If there's so much edema around that larynx, really edematous, and you decide, I think they're fine, I don't need to intubate them, you come back in later after you gave them the IV steroids and antihistamines, and it's still swollen, you're like, oh crap, we gotta intubate. And now you gotta stick a tube through that big old fat larynx now that's all swollen. Are you gonna be able to maybe get that tube down? Probably not. So have a very low threshold to intubate the person as well. Next thing is cerebral edema, ICPs. This is common when you have very large hemispheric infarct. So this is a little bit more common when you see someone with a very large hemispheric infarct. Primarily the most common one you're going to think about here is that MCA infarct. So they get a big old MCA infarct. They knock out that entire MCA division. What happens is they develop something called cytotoxic edema. And that cytotoxic edema is basically the cells dying and just rupturing and spilling out water out of those cells. And then what happens is, as this kind of like swells over here, it starts pushing the brain tissue from this side to the opposite side. And so you start getting something called midline shift across like this area where the septum pellucidum is. You need to treat cerebral edema accordingly. So what are the different types of treatment options? There's neurosurgical options. So surgery includes what's called a hemicraniectomy. And what that means is you pop the skull off here and allow for that swollen brain to herniate through that bone flap rather than down on their brain stem. The other thing is medical management, so medications that you can use. And these are kind of temporizing measures. They're not going to be effective like long term, but they can temporize the patient. And this is things where you make them salty, baby. Remember that, make them salty. So what are the different things that you can use? There's what's called 3% hypertonic saline. There's 23.4% hypertonic saline. And then there's that good old mannitol. Probably the most significant one to remember though is this 23.4%. The whole thing with these two, the hypertonic salines, is you want to approach a very salty goal. So if you're trying to make them salty, aim for a salty goal of like 150 to 155. Why am I saying all this? Here's some normal healthy tissue cells. So this brain's swelling, right? There's what's called the Monroe-Kelly doctrine, where you have blood, CSF, and brain inside of the skull. Whenever one of those increases, it starts to increase the intracranial pressure. So shrink one of them. What can I shrink? Shrink the brain tissue. So how do I do that? I come over here and make the blood really salty and yank water out of these normal healthy tissue cells to decrease the size of the entire brain. That's what we do when we give these kinds of medications. Okay, seizures is another common complication that can arise whenever someone develops an infarct, but it has to be really important to remember this. It's usually a cortical infarct. So it has to happen really kind of like near the cortex. When someone has a cortical infarct, that's where the cell bodies of the neurons are, the gray matter of the cerebral cortex. And what's really important to remember is that those neurons, if they become injured or damaged later, this can become a focus of like an epileptic source, really. And it can lead to things like seizures, like focal seizures, or maybe seizures that become like they're focal and then they generalize. So generalized seizures, what the heck does that mean? They go full on tonic-clonic, thrashing, or they have what's called non-convulsive status epilepticus, where they don't actually have any kind of really convulsions. They have decreased mental status and gaze deviations, just abnormal behavior. So whenever you think about that, you need to treat these patients with anti-epileptic drugs. And there's so many different types there. Or maybe you need to be a little bit more aggressive and you need to use really significant sedative medications. So what do I mean by that? Sedative medications are anesthetic medications. So things like propofol, for example, just mentioning one of them. But AEDs, there's so many of these. There's valproate, there's fosphenytoin, phenytoin, levetiracetam. There's so many of them. We're not going to talk about them right now. But treat those if that happens. So aspiration pneumonia. This can happen because if someone has an infarct right within the brain tissue, so let's say here's the brain tissue, nerves are going to be coming down here to control swallowing, right? So there's a lot of nerves that control swallowing, and if you infarct a part of the brain tissue that is involved in that, they can develop something called dysphagia. And the problem with that is that if you infarct the ability to swallow, what if you have a lot of these secretions that are kind of sitting here in the oral cavity? Usually what you want to happen is those to go down the esophagus. But if you have difficulty being able to swallow, where may those secretions maybe where they go? Right down here into that larynx, down into the lungs, and start brewing a pneumonia. That's where we don't want that to go, right? So what do we do to prevent this kind of thing from, someone having dysphagia from their stroke? One of the big things to do is to get what's called a speech evaluation to make sure that they actually have the ability to swallow. If they don't pass their speech evaluation, they maybe need a food, like a feeding tube, so that you can feed them another way that we kind of bypass this kind of event happening. And so maybe you have to put in like a PEG tube or a feeding tube, like a Dobhoff or like a nasogastric tube. Now, if they develop an infection though, because of that aspiration, what do you treat that with? You give them antibiotics, right? Broad spectrum antibiotics until you get cultures back and figure out what the cause of it is, and then narrow it down. Ninja Nerds, you beasts, we made it through acute ischemic stroke. All right, Ninja Nerds, in this monster of a video, we talk about acute ischemic strokes. I really hope that it made sense, and I hope that you guys did enjoy it and learn a lot from it. All right, Ninja Nerds, thank you, and as always, until next time.